All right, welcome back, everybody. So we are going to jump into peripheral nerve stimulation. Raise your hand if you do peripheral nerve stimulation. All right, lots of hands go up. I think more than we're seeing from other forms of neurostimulation. So there has been a huge growth in this area, and a big shout out to all the societies and individuals who helped with the reimbursement for this particular field. I think where we are with peripheral nerve stimulation is where spinal cord stimulation was in the late 90s, frankly. So I think the next 20 years are going to be really, really impactful for this particular area of neurostimulation. And if you're not already doing it, get into it, because it is simply the difference of putting a wire in through the needle versus injecting a steroid or putting in a radiofrequency probe. So it's not that much more difficult, and you can really help patients with sustained pain relief rather than temporary relief. So you know who I am, you know my disclosures here. You'll see a lot of PNS companies on there, and there's some new ones coming out that are not even at market. So the goal of neuromodulation is really to figure out which nerves are conducting the pain signal. So I look at injections as simply diagnostic tools. I tell my patients these are not therapeutic options, these are diagnostic options. I think we do a pretty bad disservice in telling patients our steroid injections are gonna help them and it's gonna last forever. Sure, we all know that sometimes happens, but we can't have our patients expecting that and relying on that. So I always tell patients the biggest value out of this injection I'm doing is the diagnostic aspect. And I think that's super important to convey, because if patients think that we are treating their pain with an injection and then the pain comes back, whether it's 2 days later or 2 weeks later, 2 months later, they may consider that injection or you a failure. And we all know that you're not a failure, and that injection wasn't a failure, even if it worked for 2 days, because you got the diagnostic information. And now, if that patient comes back and they're like, doc, it didn't work, I only got 2 days of 100% relief, I'm going, that's not a failure. I got exactly what I needed out of that. I'm sorry the steroid didn't work, but now I've got other options for you, whether that's radiofrequency ablation or peripheral nerve stimulation. So figuring out the nerve really does come back to the basics of knowing which nerves are conducting the pain signal. Next question is, how do I modulate that nerve? As I mentioned, you have different modalities, and I'll show you a slide here on the different ways we do that. Is it sustainable? So again, a lot of what we do is temporary, whether it's an injection or RFA, but neurostimulation, the whole reason I love it, I love teaching it, I love doing it, is because it's sustainable. So if it works, I can happily say this is gonna work for you for months, years, or forever. Yes, someone in the audience, all of you could say, well, I hear cases of spinal cord stimulation only working for 2 years. I just heard that just 15 minutes ago. Yeah, we're working on that. We know there are cases like that. Whatever criticisms you guys have in your mind, you're right. Let's make that better. But certainly if someone gets 2 years out of it, that's better than, again, 2 weeks, 2 months with an injection or a few months with an RFA. Is it comfortable? So great, we can put wires on nerves, but do patients feel okay? Do they have a big hulking chunk of plastic on their back? Do they have a big can in their butt that bothers them? So you gotta make sure it works for the patient. Is it economical? These devices are expensive. Spinal cord stimulators, $30,000 to $50,000. Peripheral nerve stimulators, anywhere from $2,000 to $10,000 and even up. So we just have to make sure that if we're putting these in people, we gotta be doing it for the right reason, because it's not just the payer and the patient, but you have Medicare, Medicaid, whatever else, that's the taxpayer. And as you guys know, that's gonna be a screw that's tightening down every single year. We're losing 3-4% on our reimbursement from Medicare, and we get it. The percent GDP keeps on going up. It's got to come back down. We only have so much money. All right, so methods of neuromodulation. You may not think about it this way, but your injections are a form of neuromodulation. So local anesthetics, all the lidocaine, ropivacaine, bupivacaine, pivocaine, whatever cane you use, you're actually creating a sudden classification 1 injury, frankly, to the nerve, and it's creating a neuropraxia, a temporary conduction blockade. How many of you guys have used phenol or alcohol in your injections? Yeah, so we certainly use this in palliative situations, cancer pain. This creates axonomesis. So the internal aspects, the fibers of the nerve are intact, but the axon sees injury. Use this primarily for celiac plexus issues. I've used it in other interesting applications like cluneal neuralgia, for example, where you need a neuroablative aspect, but perhaps RFA just doesn't have the ability to do that. So the one issue with radiofrequency ablation is that it's very pinpoint. Yes, we have larger lesions, as Dr. Phillips mentioned, but for web-like nerves of, like, for example, the cluneal nerves or the sacral branches or some of the sympathetic innervation, it's not a specific nerve. It's a web. And so sometimes fluid will do the job better than pinpoint needle RFA. Radiofrequency ablation, I think everybody in the room is familiar with that. Third and fourth degree Seddon classification. The endoneurium is now disrupted. The thermal energy creates denaturation of the proteins on the outside of the nerve. And that's where, we see that temporary pain relief. The nerve is still alive. It grows back. We all know that. Cryoneurolysis. So when I was a fellow, we were doing a bit of this. We had Dr. Trescott here at UW, and I remember her doing some of these cases, occipital neuralgia, et cetera. I think the major issue with cryo is that it's more temporary than radiofrequency ablation. So radiofrequency ablation has really supplanted cryoneurolysis. Also, reimbursement has gone away for cryo. But nonetheless, there are some places, especially internationally, that still do it. There's some companies here in the United States that take advantage of that liquid nitrogen through their needle tips to create that ablative aspect. And then last but not least is electrical stimulation. So again, one of the beauties of neurostimulation is you should not be damaging the nerve at all. You're not changing the functional, structural aspect of the nerve. You can turn it on, you can turn it off. And if it's working, it should last for years. A lot of different terms when it comes to this area. Peripheral nerve stimulation, yes, that's what this topic is about, this lecture is about, but you will see it confused with other types of stimulation. And your patients will come in, they're like, peripheral nerve stimulation, great, I put these patches on my elbow and I feel better, is that what that is? That's TENS. I think everyone is familiar with TENS. But there are these other types of stimulation in the middle that you should really be aware of. So to be really specific, peripheral nerve stimulation is an electrode array placed adjacent to the effector nerve. You also have peripheral nerve field stimulation, PNFS. So you put an electrode array in the area of the nerve, but you're not looking for the nerve, and you create an electrical field in that area. So it's pretty non-specific, but that gets confused. Like we have chiropractors in our area that say, they tell patients, I do PNFS, and patients are like, oh yeah, I've had peripheral nerve stimulation. Well, they're just putting in an array in a random area where their pain is. It's not looking for the particular nerve and creating the conduction blockade we want to see. PENS, it's a little bit deeper. Basically, these electrodes go through the skin, through the dermis, into the muscle, and near the nerve. But again, there's no visualization of the nerve. So PENS is kind of an older idea. I don't think you guys will hear about it much. But again, if you ever read about it, it's there. Percutaneous neuromodulation therapy. It sounds good. Sounds like, yeah, that sounds great. But again, it's sort of this idea or term that came in, and they just place it into deep tissue. So they have these stiff filaments, and it's basically an array of filaments that are stiff, and they just push it through into the deep tissue and then create an electrical field. So again, these three in the middle are very non-specific. They're not looking for, again, the nerves. They're just kind of looking at where the pain is. The patient says, yeah, this is where it is. Or maybe they're taking advantage of meridians if they're a traditional Chinese medicine specialist, and then you applying that. But PNS is very unique, and you've got to document this. If you place your electrode, you have to describe the nerve you're going after. That's one of the key things for the CPT code 64555 or 64575. You must describe how you're getting to the saphenous nerve, how you're getting to the femoral nerve, how you're getting to the suprascapular nerve. That's one of the key things. That's what differentiates it from these other forms of stimulation. So peripheral nerve stimulation is actually older than spinal cord stimulation. These are just some of the old things that were tried in the 19th and 20th centuries. Electrical stimulation. You can see this interesting box out of Paris with the objects on the right that are connected to this charge capacitor that you would then apply. God knows where they put those things on people's bodies, but nonetheless, you can use your imagination. There's the electreat. You'll see this in pretty much every historical neurostimulation lecture, the American version of neurostimulation. So they put these patches on people. It's sort of the precursor to the TENS unit. You heard from me yesterday when I talked about spinal cord stimulation. Remember that guy, Norm Shealy, the neurosurgeon out of La Crosse, Wisconsin, did that? In his article that was denied from every neurosurgical journal, but was accepted in, anyone know which journal? It's on the slide. Anesthesia and Analgesia. An anesthesia journal accepted it. That's awesome. In the opening paragraph, I know it's a little bit wordy, we're all a little tired or hungover, but I'll read this. Since submission of the original paper on experimental observations, Wall and Sweet, Pat Wall, Sweet, neurosurgeon who did the open dissections of PNS, have reported that peripheral nerve stimulation can produce specific focal analgesia and anesthesia. We have confirmed the results in 10 cases in which peripheral nerve stimulation was used, frequencies of 20 to 100 counts per second, or that's their hertz, currents of 0.5 to 1 milliamps, and pulse widths of 0.5 milliseconds have resulted uniformly in analgesia of the nerve's peripheral area of innervation. With stimulation of the peroneal nerve, however, no decrease in sensation could be elicited in the lateral part of the foot. This emphasizes the impracticality of peripheral nerve stimulation for relief of diffuse pain. He's not wrong, but that statement condemned peripheral nerve stimulation. This article, which every neuromodulator should know or has read, you read that, and this guy is saying peripheral nerve stimulation doesn't work. He was just describing one particular target, the peroneal nerve, as far as focal and analgesia versus diffuse. But a lot of people left that paper going, oh, peripheral nerve stimulation doesn't work. And so it really killed a lot of the innovation in peripheral nerve stimulation because of this. Everyone kind of looked at going more central. Let's look at the spinal cord, even though peripheral nerve stimulation predated spinal cord stimulation. So now let's go to 1984. We have some animal work looking at conduction blockade using peripheral nerve stimulation. This is in a rat model, a primate model, in which they were able to see the use of peripheral nerve stimulation seemed to reduce the pain signal transmission of noxious stimulation. So this was sort of like, hey, maybe there is something to peripheral nerve stimulation we were missing. Certainly Sweet, the neurosurgeon back in the 1960s, prior to Shealy's paper, was seeing success. They were putting in open electrodes in the forearm for distal extremity pain of the upper extremity. So from the 60s to the 90s, peripheral nerve stimulation is primarily a neurosurgical procedure. This was done with open incision, looking for the nerve, placing these bipolar or quadrode electrodes along the nerve and suturing it either on the nerve or adjacent to the nerve. What's really evolved in the last 30 years is the advent of ultrasound. The lead design is now much smaller. You're going to see all these different companies have very, very unique leads rather than these huge paddles. Energy transfer design has changed. So as I mentioned, in 67, you had a huge generator wired to the spine. Now we've got wireless transfer devices. It's pretty wild. It's pretty awesome. Reimbursement has also changed. So as a fellow, I was always like, what are you talking about? Why does reimbursement affect anything? It affects everything. It's everything. I remember Doug told me this early on. I was an academic, so I was like, why does he care about like another $100 for a CPT code? It matters because the amount of money you get, it's not just what goes to you and your family, but it's what drives your practice. It's what drives your value. So reimbursement is a very big deal. And Doug and I and probably Neil, we're also involved in helping get these procedures approved and what their relative value unit is and how much you get and for everything you do. And we all have this pie, and every specialty wants a piece of that pie, and the government keeps on reducing the Medicare budget. So it is a free-for-all, eat what you kill environment, but nonetheless, it's super important. So that reimbursement bit, 2017, where it really bumped up PNS, has played a huge role in allowing us to do more of it, but that doesn't mean it's here forever, guys. If we don't prove that this works and is economical and helps patients stay off of the other therapies and clinic visits, then that will go away too. So this is a very important time for us, this next 10 years. All right. So PNS, you might be thinking about it as, all right, this guy was talking about spinal cord stimulation. There's a spinal cord, all right, dorsal columns, get it. Peripheral nerve stimulation, I find these nerves. I saw that first slide, like the bodies exhibit. But we have to go deeper than that. We have to go into the nerve fibers. It's not about this nerve being a cylindrical unit. So this is my pizza diagram I crudely put on. And so as you guys know, it's not just for your boards. It's actually really important to understand each aspect or function of the nerve fiber. So you have your A alpha through delta, your B's and your C's. So if you put an electrode array, let's say you take a spinal cord stimulator lead like we did yesterday, and we just put it against the peripheral nerve. As you can imagine, you're going to change your anode cathode array, you're going to create an electrical field, and then you're going to create a field on one aspect of the nerve, right? So you have to understand which sides of the nerve, how big your field is, how big is that nerve. Is this nerve a sensory-only nerve? Is this nerve a sensory and motor nerve? Is this nerve a parasympathetic versus a sympathetic nerve? So you have to understand exactly what you're doing. It's not simply I see a nerve, put needle in, put wire in, and I'm done. You have to really understand what are the nerve fibers doing and what is my goal. People understood that electrode array could only create a field in one aspect of a nerve. So there was a company, there is, but isn't really used commercially, that decided to create a cuff around a peripheral nerve. So a circular cuff you actually place surgically around it. Great idea. Problem is, anyone guess? What's the biggest issue with putting a cuff around a nerve? What's that? Ischemia? That wasn't the issue. What happens over time? Scarring. Yeah? So great. See the nerve, dissect it down, put this cuff, wrap it around it, and then you're thinking you're great, you're getting great outcomes, and over time, naturally, foreign body round nerve scarring. And either the scarring would lead to adhering, or the scarring would lead to issues with moving, and the patient would feel stretch or pull. And so that's one of the challenges with, even though the idea is great, let's get that field surrounding the nerve, there are other issues to deal with. And then you have a unique lead design, specifically with SPR Therapeutics, in which they're using monopolar stimulation. They're creating a large electrical field. And the beauty of this is you don't have to be on the nerve. You can actually be 4 millimeters, 5 millimeters away from the nerve and create such a large electrical field that you create an impact. So again, you have to think about these things with all the different companies that are out there. So this is a bit of a wordy slide, but the real importance of the slide is to say, understand the neural pathway, understand with which product you're using, where do I need to go, and what is the field of stimulation I'm going to create, and then proceed. So I'm going to walk through some of the examples. So this is surgical peripheral nerve stimulation. I grabbed this picture from Dr. Goldfeld, who was here at University of Washington when I was and Jen was, 2010. He's honestly who got me really interested in this field, and he said, the future is this. And at that time, he was literally working with the surgical department at UW to do some of these cases. So how do you maintain relative location to the nerve? In these cases, open surgical dissection, scar tissue, as I mentioned, is a major issue. You can create damage directly to the nerve, whether during the surgery or over time. You can see here, you can create stretch injuries. Incision and collateral damage, so what else is going on? And then let's say you wanted to address the median nerve. Carpal tunnel went awry. Carpal tunnel surgery went awry. Got a median neuropathy. Great, I can put that paddle there, but how am I going to get it to the energy source? Do I have to cross joint lines? Is that going to be an issue for that patient moving around? So that's one of the major issues with surgical PNS is how do you deal with the patient comfort factors? This is the system I'm going to show you today. It's the BioNest peripheral nerve stimulator system. BioNest was bought by Bioventus 2 years ago, so it's now Bioventus, but nonetheless, been around for over a decade. Creates you do a little small cut down, really stab incision. I'll show you with the needle, stimulating probe, dilator, how we get it to the nerve. Uses radio frequency to electronically transmit to the receiver end of the lead, which I'll show you right here. This bit, although this is not working, maybe Ben will tell me how to turn this on. Well, am I doing it wrong? There we go. Sweet, great. So this is the receiver end of the lead. These are the electrodes, 4 electrodes right here, and then you can see right there, there's tines. So that reduces migration. This is also a stretchy lead. You can it's 14.5 centimeters in its native state, but you can really pull it wide. Sure, you can pull it till it breaks, but it really does stretch. So that's really nice sitting in the patient's body. They don't feel the movement of the lead. This is SPR Therapeutics Sprint system. As you can see here, it's a microcoil. This is a blown up, magnified version of what it looks like. Here you can see it. This is the distal end. It's got a little hook. That hook is actually a key component of why you get that large monopolar field of stimulation. This hook also acts as the tension aspect, the anchor. So again, every company knows that migration is an issue with these devices. This is a temporary system, okay? So this isn't a system that you leave in forever. It is FDA approved to 60 days because what happens is you put your needle in, you put the wire in, you take out your needle, and this hangs out of your skin, and then it connects to these connector boxes. That then connects to this patch, and then you can increase your intensity, as they call it, which is a product of frequency and amplitude, and that's what the patient can experience or feel. They can take off the patch and change it out, the dressing, every 3 days. So if they need to take a shower, they can do all of that. But after 60 days, per the FDA, the wires can be removed. You might be asking, well, what if a patient's doing really well? Can you leave it in longer? I had a very interesting case of a cancer patient who had a tumor around her femoral nerve. She was undergoing treatment. She couldn't walk. I ended up putting this at the L2 and L3 nerve roots exiting the spine because I couldn't get in anywhere else. And she also had to be on Plavix because the tumor was compressing her femoral artery and vein. So she was at risk for clots. I left this in for 6 months. The FDA makes these statements to help you and us be safe, but risk versus benefit in this cancer patient who otherwise couldn't walk and otherwise would need opioids, which would make her constipated and drowsy, et cetera. Anyway, we all thought she was terminal. The happy side of the story is she got put on experimental immunotherapy and her tumor went away. And she says to this day, this simple device that took me 15 minutes to put in saved her life. Because she said she would not have gone on if she didn't have pain relief. She needed those months of relief to get to where she got. And so there are unique things where this patient presented to me, I'm thinking, here's my algorithm for cancer pain. Nothing works because she's on Plavix, et cetera, et cetera. I don't know how I'm going to get to this. I can't do spinal cord stimulation on Plavix. Can't do DRG stimulation on Plavix. Let's try something different. And when you think outside of the box, you can really impact someone's life. But you're not going to see a study about that. What's unique about a microcoil here is that you create this fibrotic ingrowth. This is one of the reasons we believe the infection rate with this system is extremely low. It's basically 0%. And you think about this, you leave this in, I mean, you wouldn't think about leaving catheters in your patient for 2 months, right? You wouldn't. You would be worried about infection. As anesthesiologists, we talk about this all the time. Like, if they have an epidural in the hospital, we're like, ooh, 7 days, ooh, we better take this thing out. We're worried about infection. 60 days. Hardly any infections. It's really amazing. And you've got patients at home, taking these things on and off. So really, really cool. Curonics is the new term for StimWave, been around since 2014. You can see here the idea is having, again, receiver, electrodes, but they wanted to do everything. They want to do spinal cord stimulation. They want to do peripheral nerve stimulation. They even say they do DRG stimulation. It's not FDA approved, but it is FDA cleared for that. They've gone through some internal issues I'm not going to go into, but this is a system you might learn about, hear about, et cetera. And then you have Nalu. Great engineering. They have this micro implantable pulse generator. This is a ceramic device. All of the electronics, if you will, the chip is all in here. The energy, the capacitance, the battery you think about is not inside this. It's here, outside, this therapy disc, as they call it. So what happens is you place this in a location where the patient can wear this, and then it wirelessly connects and transfers energy through this to the lead. And you have different leads you can choose, quattrodes, octrodes. You can use this for spinal cord stimulation. You can use this for peripheral nerve stimulation. You're able to control it through your own phone. So this is really a great technological advancement, but you have to understand all the different aspects of it. And then there's Mainstay, which they have now their 3-year going on a 4-year data coming out. This is for multifidus muscle dysfunction. So what we do is we place leads, as you can see here in this array, towards the medial branches from an inside-out approach. You're not taking your traditional RFA approach. And why is that? because if you do that, there's a high risk of lead fracture going through all those paraspinal muscles. So they determined by doing this technique from the inside out, you go through less muscle, you get to the target nerves, and you create this motor contraction that you cycle through daily. What's really interesting about their data is you don't see immediate relief and then relief going on like you do with spinal cord stimulation studies. You see, in general, continued improvement over the years. I'm looking forward to their 4-year and 5-year data because I expect it's going to get better and better and better over time. The CAN is very similar to spinal cord stimulation, but again, we're not in the epidural space. We're to those medial branches. So this gives you a table of all of these different companies side by side by side. There are more coming, which I can't talk about until they're commercial, but this is a really hot field. There are different nerve targets I'll quickly go into. So these are some of the main ones you guys should learn. Of course, there are hundreds of nerves to learn about, understand, but these I think are the most important ones. I'll quickly get through them. Here's the suprascapular nerve coming through the suprascapular fossa, comes out laterally to the glenoid, and here's the axillary nerve wrapping around the humeral neck, adjacent to the circumflex artery. You can use ultrasound, as you can see here. You can use fluoro. I used to be very purist and say, you must know ultrasound, you must see the nerve, you must see artery. But I see that, not everyone does ultrasound. You can do it with fluoro. We see great outcomes. So I think I'm more open to saying, yes, do whatever works best for you, what you're most comfortable with. Just make sure you're doing it safely. One of my criticisms of fluoro is you don't get to see the vasculature. So if you stick a lead or a needle in there, you're like, oh, it looks good, but you have no idea what you're actually puncturing. So that's why I like ultrasound. I think there's a degree of safety there. For the knee, saphenous nerve coming down, sensory only. If you go proximal, you'll get some motor, but from the middle of the nerve, distally, it's sensory only. This is a common location for trocars to puncture the infrapatellar branch of the saphenous when patients have arthroscopic knee surgery, and of course, if they have a total knee arthroplasty. Great target for knee pain, especially medial knee pain. So I have a patient, who has medial pain only after an arthroplasty. I plan on stimulating him right here next week. This article out of Toronto shows you the different branches that the infrapatellar branch can take. I wish all patients looked like this. They don't. There's variability. So you got to find the nerve. You have to understand the pattern. That's why the injections are helpful. Here's some of the evidence. One of the knocks on PNS is we don't have good evidence. There is a lot of evidence, like you saw with Regen, but the question is, do you have really good evidence? It's not great. I'll be very frank. I ask every company, invest in the evidence, otherwise we're going to lose the reimbursement. These studies are expensive. They cost millions of dollars. It's not easy for them to do it. But the more we create that pressure, the more we can potentially get to the kind of studies we need to see in the space. Doing a study in the space is, I would say, 100 times harder than spinal cord stimulation. You could take 100 of us from different backgrounds. We're all going to get the leads, T8, 9, 7, whatever we need to do. For PNS, you take 100 of us. If you took pictures of where we place our leads with those nerves, they're going to look totally different, right? Some use fluoro, some use ultrasound. Some are just like, I'm done. Some are really, they spend an hour just like, stimulation on, stimulation off, So everyone's different about how they do it, and that's one of the challenges, the variability in how we all do PNS. Nonetheless, if we standardize it, we can start to study this and really understand outcomes. This is a paper I wrote with Dr. Tim Deere, a review of bioelectronic implications for the peripheral nervous system. It's a great review article on all the cool things we're doing with PNS, not just for pain, for all sorts of things, overactive bladder, rheumatological conditions, epilepsy. So there are a lot of potential future targets that we as pain physicians can get involved with, even if it's not related to pain. And then complications, there are a lot of different issues that can occur. You can kind of figure these things out, kind of similar from what you see from doing an injection, but the difference here is we're putting a lead in. So just understand all of these particular issues. All right, Doug, I'm going to pass it to you to do some Q&A. I'll go in and we'll get this rocking.
All right, good morning, everybody. Questions, comments for Ramo or anyone? What's the biggest complication associated with peripheral nerve stimulation, other than scarring? Lead migration. Right. So some of these leads have tines on them. They are designed to be secured in place, but they will migrate and they can migrate, so you have to be careful about this. Most of the ones we've seen over time will migrate, and you have to make sure and anchor them. The appropriate technique to anchor them is fairly straightforward, but just remember that. Leads we just saw in the knee were, and this is about 2 weeks ago, were migrated down to the ankle. So, I have this really bad pain. It's right here, and it's really hot. Oh, okay. So just kind of remember that. So we will get Ramo suited up and started for a peripheral nerve demonstration here just momentarily.
Bill,
Yes.
follow-up question on yesterday with the SI joint fusion. How does SI joint ablation fit into your treatment algorithm?
Fits in typically very well. So here's something about SI ablation, and that's also emblematic of strategy for reimbursement. So Ramo mentioned reimbursement. He mentioned that we were working on it, and that's absolutely true. So SI joint RF is typically very effective. It tends to work about 6 months before the rebound. There's a great study by Vanaclosia that says SI fusion gives reduced pain and improved function. It stays there this was measured out to 72 months. SI joint denervation, medial branches of the dorsal rami from S1 to S3, pain goes down and it stays down, but about 6 months it tends to come back. There's a recent study called the Synergy study, and it was a randomized control trial that had the distal end of the relief at about 2 years. And the reason why this lasted longer than typically is because it was done, the theory is because it was done with large field radiofrequency ablation, 600 cubic millimeters of ablation. And so recently it's not done very much anymore. Pragmatically, the reason why, does anybody know why we don't do SI joint RF and why we kind of haven't even talked about it now? It's not covered by Medicare. Does anybody know why it's not covered by Medicare? I don't either, because we had a consensus MedCAC meeting, and in that meeting, it was about 2.5 hours worth of positive comments on SI joint RF, and they came back. Excuse me. They came back and they said insufficient data to support SI joint radiofrequency ablation. Does anybody know what the data is on SI joint? How many RCTs do we have on SI joint RF? Not you, Fleming. He hears me say this all the time. But so, do we have a randomized control trial? I just mentioned the Synergy trial. So yes, of course we do. Is that it? Is that all we have? 6 randomized control trials, 5 systematic reviews and meta-analyses, 1 level 2 randomized control trial, and a whole host of case series, reviews. So where does that rank? I mean, if you have 6 level 1 randomized control trials, that's pretty good, right? I mean, does knee arthroplasty have that much? I mean, that's a lot. So, I probably shouldn't tell you this, but I will anyway, since Ramo's not warmed up and he made the mistake of giving me the microphone. It's like the line from Animal House. Effed up, you trusted us. All right, so back wherever we did vertebral augmentation, same kind of stuff happened. We had the National MedCAC meeting. It was NCD, and it changed the way that we do, that we form LCDs, local coverage determinations. And so we had the meeting with NGS, and the guy's name was Craig Haug, and we had a discussion with him, very similar. And it was 3.5 hours, almost 4 hours of positive comments on vertebral augmentation. LCD came out, reflected nothing about this, and it had options for pedicle infiltration. It had requirements for a neurology input, neurologist, not neurosurgeon input, and it had eliminated the subacute category, was only going to cover acute fractures. I mean, what in the world? How did that come out of this? And so I called him up and said, LCD is not going to work. We have to have some type of adjudication. He said, no, there's no new process, no adjudication. This is it. This is what it's going to be. Okay, no. It wasn't representative of anything that was said on the call. And you do know we recorded the call, right? It's, okay, no, I didn't know that, but it's not, there's no adjudication process. Okay. I kind of wondered if you would say that, so I was in contact with Merritt, Stryker, and Medtronic, and they mentioned something about a lawsuit. And, I don't know if it's going to be independent or class action or whatever. I was also in contact with Ray Baker at the time, who was, Ray, chief of the multi-specialty pain working group, home to 13 societies representing over 100,000 members. We're going to come out with consensus statements against this LCD. Okay, maybe there's something we can do. And so we went back and presented in front of each of the Medicare administrative contracting agencies, all 7 MACs independently, until we changed it. And all of the MACs listened to us. And generally, they're very great people. I mean, you heard the bad side of the not so great people, but most of the time, in my experience, these people are very conscientious. They're professional, they're experienced, they're intelligent, they want to do the right thing. And we met with every single MAC and got the LCDs changed completely. But that was done based on expert advocacy and data and the ability to command and know the data and say, nope, that's not what it says. This is what it says. And this is where it fits. This is why we need to use it. And if your mother, assuming you like your mother and she's a nice woman, if she ever needs this, you are absolutely going to have to be able to step up and, as I like to say, reimbursement. All roads don't lead to Rome. They lead to reimbursement. And next to oxygen, it's the thing that's critically important for sustainability. And if this isn't reimbursed, we don't talk about it. I mean, you should never have asked that question, right?
As people early in their careers who want to protect this field as much as we can, what can we do? What would you recommend for us? Because it seems like it's a delicate balance.
So the little anecdote that I just related to you, does that sound a little capricious and arbitrary? It does, doesn't it? Yeah. Do you know how true it is?
Probably 95%.
100%. All true. Neil was there. I'm sorry, who was it that met with all 7 MACs? Dr. Shonard? Oh, it was you. Yeah, that's right. So it took time and expert, and the point of the story is it doesn't happen unless you have people that say, well, so the statement, it takes a village or takes a team. No, it doesn't take a team, it takes a person, right? You have to care about it. You have to, the best thing about what you guys do is you think that this is, a lot of people are expert in this. Everybody knows, peripheral nerve stimulation, spinal cord stimulation. Everybody knows how to do SI fusion. Everybody knows the data associated with that. Vertebral augmentation. Everybody knows the data. No, they don't. They don't. And the ability to wield that data as to your benefit is important. It's really not to your benefit. It's to the people we take care of benefit. And so I would say the answer to that question is 3 things. Number 1, know the data, and this is why we're trying to present this to you, in distilled format so you actually are able to grasp this, wrap your hands around it. Second thing, don't be afraid to speak up. It doesn't take a team, doesn't take a village, it doesn't take an academic medical center, it takes a person. And that's all it takes is a person that's able to wield this information to hopefully do it for the betterment of society and for what we do. We don't really ask for reimbursement. We don't do things that don't work. One of the things I hate is doing things that don't work. I mean, as we like to say, our my initial start was vertebral augmentation. Magic, miracles, and kyphoplasty, not necessarily in that order, right? Do you remember what the average pain score in the EVOLVE trial was for us? It goes from a 9 to a 1.4. So that's what we're looking for. We're not looking for singles. We're not looking for doubles. We're looking to stand at the plate and hit it over center field fence into the upper deck every single time. But the ability to command and wield that knowledge for the benefit of your patients is incredibly important. And I can tell you, it's not that common. It's not commonly done. People, would you agree with that, Neil? Yeah, it's rare. It's rare.